Hello, everyone, and welcome to the session of the NPC on clinical trials. I'm Jessica from Craig's Cause Pancreatic Cancer Society, and I'm delighted to introduce our speaker for today, Dr. Daniel Renouf. Dr. Renouf is a medical oncologist at the British Columbia Cancer Agency, Vancouver Centre, and an assistant professor at the University of British Columbia in the Department of Medicine. He received his Doctor of Medicine from the University of Alberta and completed his internal medicine and medical oncology training at the University of British Columbia and British Columbia Cancer Agency. He undertook further training in early drug development and gastrointestinal oncology at Princess Margaret Hospital and the University of Toronto, and obtained a Master's of Public Health from Harvard University. Daniel's research interests include developmental therapeutics, genomics, and biomarker development within gastrointestinal cancers with a focus on pancreatic cancer. He is the leader of the BC Cancer Agency Phase 1 program, the co-director of Pancreas Centre BC, and is the co-chair of the NCIC Pancreatic Cancer Disease Group. Evidence shows that patients who participate in clinical trials have better outcomes and improved quality of life. However, the access a patient has to information regarding clinical trials is variable between physicians. Most clinical trials for pancreatic cancer have exclusion criteria specifying the patient must not have received prior treatment, so it is critical for a patient's eligibility that clinical trials be discussed as soon as possible following diagnosis, and guidance on how to access information on clinical trials be provided to the patient. This session will educate participants on the positive outlook provided to many patients by participating in a clinical trial and highlighting ongoing clinical trials that have the potential to change the statistics associated with pancreatic cancer. So please join me in giving Dr. Daniel Renouf a warm welcome.
So as Ravi outlined, I think I've been asked to talk about clinical trials, and I really want to kind of highlight a few points in the next 30, 40 minutes. One is what's the current landscape of pancreatic cancer and the value of clinical trials. Two is really highlight what our current trial options are in Canada. And I see we have people from around Canada, so happy if I've missed a few to highlight other ones that may be opening or open in other parts of Canada. And I think this last point is key about awareness to in a very short time frame determine availability and eligibility for these trials, because we know that that patients can get sick very quickly and need to be aware of their trial options in very short term, so that we can match them ideally to the appropriate clinical trial. I think, as you're well aware, and I think just recently, pancreatic cancer is now the third most leading cause of cancer-related death in Canada. It's become the third leading cause of cancer-related death in the United States and projected to be the second leading cause by 2030. So it's really a major health problem, and there are a number of reasons why it's such a difficult to manage disease. I've highlighted some of them here. If we look at this from the top, we know that there's no good screening tests, and late detection is a major issue. Even with surgery and adjuvant chemotherapy, there's a high recurrence rate. Despite some advances in treatment, there's a lot of resistance to treatment. If we look on, moving leftwards, I think there's been a lot of advances in the area of biomarkers, but there still is a lack of need for more advances in this area. We know that age is a major risk factor for pancreatic cancer, and as the population ages, we see more of it. And I think this last at the bottom here area is a really interesting and still poorly understood in terms of the relationship between pancreatic cancer, metabolic syndrome, obesity, diabetes. And we do have a clinical trial that soon will be open, kind of exploring this. So excited to kind of talk to you about that and get your feedback on how we can modify that trial and who might be interested in opening it. So this, I'll start with a case, 65-year-old gentleman who presented with kind of typical symptoms, no significant history. has a pancreatic mass and a liver metastases. A biopsy was performed, and the pathologist tells us it's an adenocarcinoma. So a couple of things to think about, and we'll come back to this case as we go through this discussion. I think the first is there any other molecular information that may be of use? I think one area that I'd like to discuss with the group, because I see there's people from a number of different regions, is what type of molecular information are you getting from your pathologist beyond just the diagnostic? And then the second point, and really the theme of this discussion is, are there any clinical trial options? So we'll come back to this case as we go through. So I thought I'd start, and usually when I speak to kind of trainees and patients, I like to simplify pancreatic cancer into really three main categories, maybe four. The first is resectable disease. The second is locally advanced, which has a kind of can be subdivided into borderline resectable and locally advanced unresectable. And then the third category is metastatic. So I thought we'd start in the resectable setting. And I think as many of you are aware, the current standard worldwide in this setting is to have an upfront surgery. And then we used to use gemcitabine, but based on this trial, which demonstrated that there's a significant improvement in survival with modified FOLFIRINOX as an adjuvant treatment, the standard of care has now become in patients that are well enough to have upfront surgery followed by FOLFIRINOX. This area is evolving quite a bit right now, and there are a number of really interesting clinical trials in this setting that I want to spend a few minutes highlighting. The first study is the NeoPanc-1 study, which is open across Ontario and in a number of other centers across Canada, including in Vancouver. This is and I think I see Steve Gallinger as well as Grania on the call, who were really pioneers with Jennifer in putting this study together. And so this is a study looking basically at translational endpoints and correlative markers as a way for us to better understand the kind of biological characteristics of resectable pancreatic cancer. And I'll spend some more time talking about some of the science behind this later in the talk. I just wanted to outline here that in this study, patients will receive a preoperative or neoadjuvant FOLFIRINOX, have surgery, followed by further FOLFIRINOX. It's a single-arm study, but it has some really important correlative endpoints. And I think it's a really highly valuable study, and it is accruing right now. I think accruing quite well, especially in some Ontario centers. Really the field is shifting quite a bit and I'm not sure what surgeons we have on, but I see that Steve's on, that there's more and more appetite for a neoadjuvant approach. And I think this has been quite a shift in philosophy. I've seen this in BC, where I think a few years ago, the surgeons were very keen to do upfront operations. And I think as we've seen some benefits from improved chemotherapy like FOLFIRINOX, there's been kind of a shift where there's more interest now in neoadjuvant or perioperative approaches. So this is one really exciting trial, and I'd encourage you to check with your teams if this is available in a local center. Another trial in this setting is the PAC.3 trial, which is a collaboration between the Alliance Group, and Christina Ferroni is a surgeon in Massachusetts General Hospital, and she's the overall PI of the study. And it's a collaboration between the Alliance Group and the Canadian Cancer Trials Group, CCTG. In this trial, it's a similar patient population. So again, it's resectable pancreatic cancer, but this is less of a translational or correlative-based trial and more of a pragmatic trial. And it's really asking the question, should we be using perioperative chemo compared to just adjuvant chemo? So if we look at this schema diagram, arm 2 at the bottom is our current standard of care in this setting, as I mentioned a few slides ago. So the standard is to have surgery and then postoperative FOLFIRINOX chemotherapy. In this trial, patients are randomized to either that approach or a perioperative approach, where they receive 8 cycles of modified FOLFIRINOX, followed by surgery, and then 4 cycles of FOLFIRINOX in the adjuvant setting. So this is another very important trial. It's a phase 3 trial and likely will determine the utility of perioperative chemotherapy moving forward. And this is going to be open through the CCTG at hopefully quite a number of centers across Canada. And so for the surgeons and medical oncologists that are on this call, check with your teams, or if you're the pancreas leads, I'd encourage you to consider opening this trial, because I think it's going to be quite an important trial. So we're really in a good space that we have 2 really nice trials in the resectable setting, which is quite exciting. I think these are going to help define where the field moves over the next few years. I just thought, while we're in this setting, maybe to take a step back even further. And again, this is really relevant to surgeons, or if there's any gastroenterologists on the trial. The newest trial that's going to be coming through the Canadian Cancer Trials Group is this trial, which is a collaboration between the ECOG Akron group and CCTG, and is looking at management of pancreatic cysts. So they're really randomized. Patients are being randomized to 2 different degrees of surveillance. And again, I think for the surgeons and gastroenterologists, you're aware of kind of the relevance of this question. This is a very large trial, as it's going to take a lot of patients to answer this question. And the Canadian PI is Dr. Paul Carey-Nicholas at Sunnybrook Hospital. So I think this is also kind of a very interesting trial that will help define management in this setting. So again, we're really well suited in Canada in this early stage setting to have these 3 really nice trials. Maybe before I shift gears, I'll just pause there. Does anyone have any questions or comments in kind of the cyst or neoadjuvant resectable setting? Can't see the chat right now. So Ravi, please let me know if anything's popping up on the chat.
Yeah, there's one question from Dr. Teskova for PAC3. Is the value of CA19-9 taken into account when defining resectability?
Yeah, so that's a good question. I'm going to just see if I can pull up my chat screen here so I can see it. Here we go. Yeah, so there is not a specific cutoff for CA19-9 in terms of saying that someone would not be resectable. That decision is based on the CT scan. But it's a very good point that that will be, one of the kind of exploratory endpoints is to look at if someone obviously has a very high CA19-9, you worry that there's a very high likelihood that they would have micrometastatic disease if there's nothing seen on CT. So CA19-9 measurements are included, but it is not specifically defined as a reason to not operate on a patient. Okay, well, so those are kind of the 3 trials in this setting. And again, I think they're really 3 exciting trials, and we're fortunate to have them open. I think just to kind of highlight from my perspective, and I think different groups have different abilities and different successes in doing this. And I think the group at McCain Center with, that Steve and Grania are a part of, has been a very nice model of how to build a multidisciplinary clinic with surgeons and oncologists working closely together. And for these types of trials, that's really key. Because again, if we go back to this trial, patients are randomized upfront to either upfront surgery or chemotherapy. And clearly there's very different pathways that would be taken. And it's very important that everyone's kind of on the same page with seeing these patients. So we in BC have tried to and have started a multidisciplinary clinic with the surgeons seeing patients in tandem with the oncologist. And I know that there's different models across Canada, but I think that's really key to make these trials work, is to have a close connection with the surgeons and the oncologists. It doesn't necessarily need to be a multidisciplinary clinic, but I guess the lines of communication need to be very open between those specialties to make this type of trial work. And again, I think for groups that are thinking of opening these types of trials, kind of a model where you have surgeon and oncology champions that are really committed to this trial is key to make it successful. Okay, so I'll move on from there to kind of the metastatic setting. And I'm going to set the stage for a few slides for some of the trials that are happening right now in the metastatic setting. And so I think, again, all the medical oncologists will be well aware that there have been advances in chemotherapy options, but pretty modest advances over the last 20 to 30 years in pancreatic cancer. And we're still in a position where, sadly, we make a lot of treatment decisions based on factors such as performance status, age, comorbidities, which is not where we want to be, not where a lot of our colleagues are that treat lung cancer or lymphoma or even now prostate cancer, where there's a lot of more molecular information being used to guide treatments. And so clearly we need to move away from this model, and we need to kind of get to a model where there's a lot more molecular information being used to guide our treatment decisions. And so I think that, the question is how do we move from there to where we want to be? And I think there's kind of two avenues that we need to make progress in. The first avenue is we need better drugs and more targets. And so this is an old slide, but I like to show it still because it's actually a little bit depressing, I would say. But the pancreatic cancer has been one of the kind of pioneers in terms of understanding the tumor microenvironment. So we see a lot of these blue blobs that are cancer cells, and then all of this other stuff is other components of the tumor microenvironment. And in this slide, which was kind of cutting edge in 2015, demonstrates that there's a lot of drugs that have been developed that target different components of the tumor microenvironment. And I guess, why do I say the slide's a bit depressing? It's because most of these, if not all of these drugs, have undergone clinical trials that have not shown significant benefit. So I think we've learned that while it's important to target the tumor microenvironment, that alone has relatively modest activity. And I think our kind of takeaway from that is a number of things. One is that we really need to understand, are there subsets of patients that are going to benefit from these types of approaches? And a one-size-fits-all approach clearly doesn't work in pancreatic cancer. And two, I think, is that likely we're going to require combinations of a lot of these approaches. And when we just go with one of these on their own, it doesn't significantly impact outcomes to the degree that it's actually clinically useful. And I think maybe the third message is that despite a lot of advances in our preclinical models and preclinical testing, I would say all of these drugs had very nice data in the preclinical setting showing activity. It did not bear out in the clinic. So despite these advances, we need a lot of further progress in the preclinical drug development arena in pancreatic cancer. So, I thought I'd just highlight one study that is in a way targeting an element of the tumor microenvironment, and that's the CA9 pathway, which is a component of pancreatic cancer cells ability to survive in a hypoxemic environment. So this is actually a really nice story, because this drug SLC0111 was developed by Shaki Dedhar's lab. He's a senior scientist, distinguished scientist at BC Cancer Research Center. And initially, a lot of the work was done in breast cancer. And then through some preclinical work, they identified pancreatic cancer as a very interesting target. And the lab has really switched gears to be in many ways pancreatic cancer focused. And so this is a phase 1B trial, so a very early phase trial, with a main endpoint being determining the recommended phase 2 dose. So it's looking at dosing toxicity of giving this agent, SLC0111, with chemotherapy, gemcitabine. It's supported by a Canadian Cancer Society Research Innovation Grant, and it's currently open at BC Cancer Vancouver and at Princess Margaret Cancer Centre. This is a trial in the later line setting, so in patients that have already progressed on first-line chemotherapy. So I'm going to, I guess, shift gears from that approach, from kind of targeting the tumor microenvironment approach, to our need, and I alluded to this before, to better understand pancreatic cancer subtypes. And I think, again, we're moving away from this one-size-fits-all, and it's definitely possible that, and there's a number of trials happening internationally that include kind of all comers with pancreatic cancer that have a new agent added to gemcitabine nab-paclitaxel, or a new agent added to FOLFIRINOX. But I think a lot of the progress will likely come from understanding the different biology within pancreatic cancer and targeting these cancers appropriately, and not thinking of it as one disease. And so this is a slide that, if there's any pathologists on the call, don't blame me, because this was done by a pathologist, and it's not actually accurate. But I think it's just meant to illustrate that we know there are other subtypes, but we really think of it clinically as one of these two diseases, neuroendocrine tumors or adenocarcinoma. And this needs to change. We need to think of it as multiple subtypes of adenocarcinoma. And this is some kind of more basic science translational data showing that for years now, we've known that there are important subtypes of pancreatic cancer. But our challenge has been, how can we take this information? A lot of it is driven by deep genomic analysis. How can we take this and translate it into the clinic? And I think probably most people on this session are more clinically oriented. So is any of this clinically actionable? And so I think we have made some advances in the last several years. So the first area is in BRCA mutations. And so we know that BRCA-related pancreatic cancer is a defined subset of pancreatic cancer. It has different molecular characteristics, and we know that it has different clinical characteristics. And this was from several years ago, a patient of ours that had a very good response to platinum. And there was a lot of case series of this. And most recently, very nice trial led by Eileen O'Reilly in New York has really demonstrated the utility of platinum-based chemotherapy in BRCA mutant pancreatic cancer. And so this has led to also our understanding of targeted therapies in this subset of patients. So this was an important trial, the POLO trial, that was the plenary session at New England Journal, plenary session at ASCO and a New England Journal publication, demonstrating the utility of using a PARP inhibitor, Olaparib, as a maintenance therapy in the BRCA mutant population. I think if we link this back to ongoing clinical trials, again, I think the way forward is to have clinical trials in subsets of pancreatic cancer, but there's some challenges associated with that. So one trial that is ongoing in the US right now is in resectable pancreatic cancer, where patients receive kind of standard adjuvant therapy and then are randomized, if they have a BRCA 1 or 2 or PALB2 mutation, to receive standard follow-up after completion of chemotherapy, or maintenance PARP inhibitor after completion of their chemotherapy. So this is a really nice trial design, but it's a challenging trial to really accrue patients to, because it's a fairly small subset of patients. And I think, again, from a clinical trial scope, that's the balance, that it's in some ways it would be nice, the more we can define a cancer type and tailor our therapies, the smaller subsets of patients we're talking, which is good in terms of individualized treatment strategies, but it makes for challenges in terms of accruing and completing clinical trials. So that trial is an interesting trial that I know the group is interested in expanding internationally, but it's a very challenging trial to, I think, in our centers to really accrue to. This is just to show that, and I think many people are well aware that in addition to BRCA mutations, another kind of clinically actionable aberration in pancreatic cancer is mismatch repair deficiency. And we know from really pioneering work from the Johns Hopkins group that mismatch repair deficient tumors of multiple origins respond to immunotherapy approaches. So I think if we go back, some of the early questions I asked about our case, is there any other pathological information we'd want from on this patient, or any molecular information? So I think right now, as of 2021, I would say that all patients should receive mismatch repair information, and this can be done by immunohistochemistry. And in Vancouver, that's done in some hospitals, at least on a reflex basis. So every single pancreatic cancer is checked for mismatch repair status. And also, every single patient should have BRCA testing done. And so I know that varies province to province. In BC, we have a rapid hereditary assessment program. So every patient can have access to a rapid assessment for BRCA mutations. And I think we found in our program that a lot of patients that have been identified to have BRCA mutations, germline mutations, did not have any significant family history and would not have been candidates for testing under the old guidelines. And I know there's new international recommendations that are coinciding with this recommendation. So I think as we try to define subsets of pancreatic cancer, it's important to integrate a lot of the basic science and translational work with the clinical work. And I think what's happening across Canada now, which is really exciting, and I think we have some pioneers of this area, and Steve Gallinger being one on this call, is how can we integrate genomic work with the clinic? And so this is, I think, a nice figure done by Emma Titmus at our Genome Sciences Center, just demonstrating how this can work. And this comes from our local study in Vancouver called the Personalized Oncogenomics Program, which is a clinical trial where patients are consented, have a biopsy, undergo whole genome sequencing, whole transcriptome sequencing. It's reviewed at a tumor board. There's hereditary team included, and then clinical decisions are made, and it can integrate with clinical trials. And then subsequently, there's monitoring and health economics elements. And so I think, we can touch on this a bit at the end of the discussion, but there's a lot of potential for further trials along this theme moving forward through a couple of national initiatives. And one of those initiatives is the Marathon of Hope Cancer Centers Network, which is federally funded and supported through the Terry Fox Research Institute, and really supporting trial designs in this type of setting where there's linkages between genomics and clinical trials. So I'll come back to that at the end. This is a TFRI program that really, through the support and mentorship of people like Steve, we have a great team, Steve, George, Oliver, and Jennifer, that many of you work closely with, I think a number of these people, as well as David and myself. This was started about, now I think about 5 or 6 years ago, looking at how can we do more profiling of pancreatic cancer across Canada. This was also supported generously by Pancreatic Cancer Canada, as well as the PMH and BC Cancer Foundations. And so in this is the kind of schema for EPIC, where the COMPASS trial that has been led out of Toronto, as well as the PanGen trial, which is led in Vancouver, Calgary, Ottawa, and Edmonton. And I should mention that the COMPASS is also open in Montreal and Kingston, has fed in to this is a kind of integration of clinical information and genomic information. So I think actually I show the schema here. This is the schema for PanGen and similar for COMPASS, that all patients have a baseline. So they have to have newly diagnosed metastatic pancreatic cancer, and they undergo baseline biopsy where they undergo whole genome, whole transcriptome analysis, as well as some other correlative studies. And then they receive standard of care chemotherapy. But of importance is that there's a clinical trial grade follow-up, meaning they have CT scans every 8 weeks. There's close follow-up, and all of the data is collected, and it gets entered into a data set, this EPIC knowledge bank, which we're building right now and hoping to have as something that scientists across Canada and internationally can access this information. And this can feed into other clinical trials. So PanGen and COMPASS are clinical trials, but not really looking at drugs specifically as the main endpoint. They're looking at the genomics and identifying subtypes of this cancer. But clinical trials can be integrated into it. And so the PA7 trial, which was a trial of chemotherapy plus immunotherapy run across Canada, was itself a negative trial. So we didn't see a significant benefit from adding immunotherapy to chemotherapy. But we did obtain a lot of interesting correlative information looking at what subgroups of patients might benefit from immunotherapy. And that some of that work is ongoing. And so I think in many ways this was quite a successful trial because of the correlative work that has come as part of it. And this can also feed into different national trials. And an example of this is the Capture CCTG Capture trial, which I'll speak about again in a few minutes. So again, this is the PanGen trial. Right now, this trial is open. PanGen is open in Vancouver or British Columbia, Calgary, and Ottawa. It's closed now in Edmonton. So for anyone who's calling in from those sites, if you're interested, this is for patients with upfront diagnosed metastatic pancreatic cancer, and they have to have biopsyable disease. In Toronto, and I see there are some people in Toronto, and they can comment on this, but they've shifted gears into a new trial, which I'm going to get into, which I think is really, really exciting, and the way forward and really understanding this in a few slides. So I think if we go back to the case, and again, we look at what's how obviously I think people understand how these trials influence our understanding of the genomic landscape of pancreatic cancer and help us kind of move the field forward. But what's the benefit for a patient on these trials? And so obviously not every patient benefits, but this, I think if we go back to our case, if you remember, they had mismatch repair status was stable. They didn't have a BRCA mutation, but they did undergo whole genome sequencing. Ooh, sorry about that. And had an NRG1 fusion identified. And so I think one of the really exciting things of this work that's come through COMPASS and PanGen is identifying kind of new actionable targets in pancreatic cancer and helping to kind of change the field moving forward. And so through PanGen at the time, and now there's been more identified, 3 NRG1 fusions, patients with these drivers were identified. And based on some work we had done previously looking at targeting these fusions with a ERBB2, so really a pan-ERB inhibitor, afatinib, we tried treating these patients with afatinib. And what you're seeing here is PET scan images, pre-treatment and post-treatment, and everything that's glowing red is kind of bad. And we see just after 4 weeks, there's quite a significant response to treatment. And this is seen in both of these two patients that were treated with afatinib. So really, this work and the genomics work happening across Canada has helped to, this is some of the pioneering work in leading to this identification of this novel fusion. And this has really led to a shift in drug development in this area worldwide. There's now 2 companies that are developing novel drugs targeting this pathway and have clinical trials open internationally. There's one company, the Mirrors company, that I believe has a trial open at Princess Margaret Hospital right now that has a novel agent targeting the NRG1 pathway. And there's another company that has a separate target, but along the same pathway, and we'll be opening that trial in Vancouver shortly. So this is a really exciting, I guess, subtype of pancreatic cancer. And I think one of the nice things that kind of came from this work, this was on the accompanying editorial, is really the thought that we think about KRAS mutations as being a main driver in pancreatic cancer. And obviously that's well known. But as more and more work that's coming out showing that really the KRAS wild type group of pancreatic cancers have a much higher chance of having some form of actionable target. And I think we're moving to a point where we should really consider KRAS testing for all pancreatic cancers for a number of reasons. One, we know that KRAS wild type tumors are more likely to be targeted. And 2, we are now developing drugs that target some KRAS subtypes. So we recently saw a patient that had a KRAS G12C mutation, which we know is uncommon in pancreatic cancer, much more common in lung cancer. But there is a drug that targets that, and we were able to access that drug for that patient. So I think the field is really changing significantly based on a lot of this work. One of the challenges, though, is that there's still a large proportion of patients that are not going to have actionable targets. So if we think, at the estimate that maybe 10% at most of pancreatic cancers have KRAS are KRAS wild type, maybe 5 to 8% are BRCA mutant. There's kind of a few percentage that might have other kind of targetable aberrations, but a large chunk is not going to have currently targetable aberrations. So what do we do with that group? So this is work that Grania, so we're lucky to have Grania on the call here, that she presented on behalf of the COMPASS group a few years ago, demonstrating the importance of transcriptome-based subtypes, not only from a prognostic perspective, but also from a predictive perspective. And so this is a waterfall plot, and everything going down is good, showing response. And we see that the purple or the classical subtype tumors are much more likely to respond to chemotherapy. And this is really great work that the COMPASS group has done, demonstrating that seems to be a differential effect, and that the classical subtypes seem to have derived a more significant benefit from FOLFIRINOX, but really not much benefit from gemcitabine nab-paclitaxel, where there's less of a differentiation with gemcitabine nab-paclitaxel. And this has, I think, led to the design of this really innovative trial, which is currently open. I think in Canada, it's just open in Toronto and Vancouver at this time. But Grania or Steve can correct me. And this is the PASS-1. So I think this is the logical next step from COMPASS/PanGen type trials, because we can always criticize those trials that chemotherapy was really dealer's choice. And a lot of the predictive findings that come from them are retrospective. And so if we really want to change the field moving forward, we need a prospective trial. And so in this study, it's really kind of building off that data. Patients are randomized, kind of similar design, that they undergo a baseline biopsy for whole genome and transcriptome analysis, and then randomized to either receive FOLFIRINOX or gemcitabine nab-paclitaxel. So this is going to be a very, very important trial, I think, on a number of reasons. Even if we take out the exciting transcriptome and correlative aspects of the study, just look at it at its very bare bones. We don't have any prospective trials or large prospective trials in the randomized setting comparing modified FOLFIRINOX versus gemcitabine nab-paclitaxel. So it's going to be quite interesting. Obviously, it's going to be underpowered to make that comparison, but I think that's going to be quite interesting. But the genomic information and correlative studies that are going to come from this are quite fascinating. One of the other really exciting aspects of this trial is that their collaboration with the group at Cold Spring Harbor, looking at organoid testing really in real time, and how, so an organoid is kind of a avatar basically of the tumor. And again, I think I spoke a few slides ago about how our limitations in translating drug development from preclinical setting to the clinic. And currently our best model for trying to do that is organoids. This is a really exciting aspect of the study where we can look at some of this really in real time, because the organoids can be developed quite quickly, and the findings in the organoids can potentially be used to inform subsequent treatment for those patients. So I think this is really, really exciting aspect. So this is a fantastic study if you are in the GTA or BC regions. And I think it's definitely something to strongly consider. And I think it's moving the field of clinical genomics and pancreatic cancer forward. So I thought, I'll just highlight a few other aspects of this. This is work done by Joanna Karasinska, who's the senior scientist at BC Cancer. And it's really looking at, is there kind of a metabolic basis behind some of these subtypes? So knowing that there's a basal and classical subtype is important, but it would be really nice if we could somehow act on that. And so she's done really interesting work showing that the basal type, or really the bad behaving tumors, tend to be more glycolytic in terms of the metabolic pathway, and the better behaving or classical subtypes tend to be more cholesterogenic. Why is this interesting? I think this is really, really exciting because we see plasticity of subtypes. And so this is some work, and I know there's other findings from the Compass group looking at this, that the subtype can shift over time. So this particular work was analysis done in a patient who had a BRCA mutation, and they were very sensitive to chemo for a long time. And then suddenly the tumor started to behave much more aggressively. And I think we often think, as medical oncologists, that, okay, well, there's been some kind of major mutation or change that has made the tumor resistant. So we did another, resequence the tumor, kind of expecting it to look way different. But in fact, it didn't look any different from a DNA level. Even with whole genome sequencing, there was very minimal differences, which was quite fascinating. It really suggests that a lot of the differences and a lot of the change in behavior is on the transcriptome level. And we found that it changed from really a classical-like tumor to a basal-like tumor, and was behaving much more kind of aggressively in a chemo-resistant fashion. And so I think this is really exciting concept, because if we understand that there's plasticity in a tumor, then maybe we can use that to our advantage and have tumors change in the direction we want them to change. And this is some of the rationale behind this study. So I guess without getting into all the background, as I mentioned at the beginning, there's a large amount of interest between the role of diabetes, glucose management, metabolic syndrome, and pancreatic cancer. And we're working closely with Jim Johnson and Janelle Kopp, who are two excellent scientists at UBC, And through Jim's leadership, was able to receive a grant to study this both in the basic arena, but also in the clinical arena. And so one hypothesis we had is that maybe kind of modifying the glucose environment can impact subtypes. And I think, so this led to the design of this quite simple study. But I think again, the oncologists on the call, on the Zoom call would probably agree with me that in metastatic or in pancreatic cancer or most cancers, we do not manage glucose levels in an extremely controlled way. Obviously, if they're very high, then intervention is taken. But if they're not very high, we do not manage it very closely. And that's quite different from some other settings. So we know in the intensive care unit or the cardiac care unit, there's very good data of the importance of very tight glucose control. So in this trial, it's really kind of a small proof of concept study where patients are going to be randomized to either have very tightly controlled glucoses managed by an endocrinologist versus kind of our standard of care. And really, we're going to be looking at a lot of correlative endpoints, but one of the, I think, really exciting correlative endpoints is going to be in terms of the RNA and transcriptome pathways, and do we see any difference in the subtypes from a classical or basal subtype? Because I think if there was a way to shift a tumor from being more chemo resistant to more chemosensitive, obviously that would have major clinical implications. So this study is really been led by Dr. Erica Sang, who is one of our fellows here. She's in San Francisco training now with Andrew Coe, and she's going to come back on staff in BC in the summer. And so I think if people are interested around the country, there's definitely potential to expand beyond BC with this study. So I think it's an interesting concept. I think this, I should have updated the slide because one of the good things of pancreatic cancer right now is that I have to update the slide all the time because we're finding more and more interesting and relevant subtypes of pancreatic cancer really on quite a regular basis. So again, we talked about BRCA, mismatch repair, other kind of homologous recombination defect tumors. In the KRAS wild type setting, we're seeing a number of fusions, so BRAF, NTRK, FGFR2, MET, NRG1, and then there's other targetable aberrations such as high TMB. And then again, I talked about these big chunks of classical and basal. And I can tell you just in the last couple of months, in my clinic, I've seen an FGFR2 fusion, a BRAF fusion, an NTRK fusion. We've had a couple high TMB patients. And so we are seeing these things and they're having major impacts on patients who are undergoing treatment. So this is happening right now, and it's very exciting. How can we act on these though? So obviously, there's a few ways to access these drugs. One is to have clinical trials. So we talked about some of the trials that are ongoing across the country, looking at NRG1 fusions. So that's one mechanism. A second mechanism is to get access from the company, and sometimes that's funded access. And so NTRK fusions, for instance, I think across Canada, there's ways to access TRK inhibitors. And then kind of a third way is through, and the ideal way, I think, as we move forward and back to the theme of this talk, is to enroll these patients into clinical trials that maybe are more basket-based. And so, one way to do that is through the CAPTURE trial. This is a CCTG-led trial that's open in a number of centers across Canada. And it's really a molecular basket concept where patients have to have some form of profiling, and then based on the results can be matched to available drugs. And so I think this was quite an innovative trial, especially when it was designed, because a number of different companies agreed to have their drugs available as part of this. So for instance, Olaparib was available to for tumors that may have a high HRD or BRCA1/2 mutations in areas that it already wasn't funded or proven. And as you can see, there's a number of other targets, and this kind of list is kind of ever changing. So I think this is a nice type of platform. If I go back to what I was mentioning earlier, and especially I'm not sure if there's any kind of junior investigators on the call, but there's so much potential right now to build upon this type of platform, either through Capture or through the Marathon of Hope network. And so I think as some of you are aware, there was recently a white paper call out through Marathon of Hope for just to kind of include ideas that you might have, and especially of interest is national collaborations. And I can say, especially of interest to me, is national collaborations that are looking at prospective studies that are including aspects of clinical and genomic assessments such as this. And there will be another white paper coming up shortly. So there's going to be a lot of opportunities to build off of this kind of concept of we're finding, finding these actionable subtypes, and let's find the right drug to treat these subtypes. So the field is really moving in this direction. I think that's very, very exciting. So I think I'm almost done. Hopefully I've convinced you that clinical trials in pancreatic cancer are really key for us to truly enter an era of precision medicine. I think one really frustrating thing that I think we all see is that despite all of the exciting things happening in pancreatic cancer, there's still a lot of times where patients won't have access to BRCA testing or mismatch repair testing, definitely not KRAS testing, and we're not able to necessarily define all of these subtypes. And one of those reasons is sometimes that unfortunately patients just get very sick very quickly and may not benefit from any of this. But another reason is that the field is changing so rapidly. We need clinical trials to kind of change what we consider standard of care is. So I think that's just so key right now. As I mentioned, we need close collaboration with the healthcare team to optimize management of these patients, and especially this is true for the resectable setting patients, where again we have some models where there's very nice collaboration with surgeons and oncologists, but that's not necessarily the way it is across the country, and that's really key. These groups working closely together for these trials in the resectable setting. And then I think just to kind of end with this message that there's a lot of excitement happening. I think we need, and everyone kind of part of this meeting, and again, thank you to Craig's Cause and all the organizers of this meeting. It's great to have these meetings about pancreatic cancer because we need, as a community, need to be the advocates for more energy, more resources, and to bring hope and optimism to our patients that are dealing with this cancer. So with that, I'll just thank, there's a huge number of people that are involved across British Columbia, our close collaborators across the country, and this is including some of the Compass team, the PanGen team, people involved in these studies, all of the funding that was associated with this, and in the kind of broader genomic sciences team as part of the BC POG project. So with that, I'll stop. I see some great comments from Grania and Steve, and so yeah, please let me know if I've missed any trials. I think Steve's mentioning that. And I know Granny mentioned that Compass is now closed, but obviously PASS1 is open. And Steve's saying that there's a Compass PASS1 type trial that's going to be open across Ontario, Prosper Panc, which is going to be run through OICR. So that's fantastic news. And so that's great to have that option available across Ontario. So yeah, I think really, really exciting stuff happening in the advanced setting and in the resectable setting. I will just say one area that I think there's a bit of a lack of trials is in the borderline resectable or kind of early locally advanced setting. and there's a lot of controversies in that area. There was recently a trial showing kind of a limited role of radiation, or maybe no role for radiation in that setting. And I think that area is still quite controversial worldwide. So I think it would be nice if we had an option, because I think there's a lot of patients that are now kind of falling into that category, and it'd be nice to have more trials available for that group as we move forward. So yeah, there's a lot happening. There's a lot of potential. So I think if people on the call have ideas, there's many ways to kind of help build these trials. And if you're just interested in knowing what's available at your local centers, there's a lot available across the country.